Hello, Kaz Wilcox speaking. The purpose of this PowerPoint is to provide a summation of the more comprehensive discussion paper called Toward Defining a Sustainable Pedagogy to Advance Continuous Professional Development for Existing Chronic Care Practitioners. Bit of a mouthful, hey? The objective of this PowerPoint and the discussion paper is to support the Chronic Care Steering Committee to critique current practice and conceptualise a sustainable training and education model that will advance professional development for existing chronic healthcare specialists within the region. For those unfamiliar with the committee, the collaborative works on behalf of the Hume Health Services Partnership and was formed in response to changing market dynamics and subsequent directions set by the 2005 National Chronic Disease Strategy, and more closer to home, the partnership's Hume Region Chronic Care Strategy, which was released in 2 years ago. The committee's focus on workforce skill capacity and training is driven by the growing impact of chronic disease in the region and the need for an improved sustainable pedagogy that is responsive to the needs of both the local workforce and people living with a chronic health condition in the Hume region. The exploratory research undertaken to inform this paper was qualitative in nature and used three methods of information gathering and stakeholder consultation. 1. A literature review. 2. Peer review in group workshop settings. And 3. In-depth interviews with key stakeholders. The target cohort of this paper is limited to existing qualified healthcare professionals who work in the public primary healthcare sector. Also, importantly, please be aware that undergraduate or pre-registration students and the related curricula are out of scope with this particular exploratory study. Also, the private sector, such as private hospitals and GP practices, are at this early stage out of scope. Across the Hume region primary healthcare sector, there is a growing need to define sustainable approaches that will advance professional development for our existing chronic healthcare professionals. The intent of this exploration study was to acquire preliminary insights from cross-sectoral experience on both current workforce issues and contemporary teaching approaches in health professional education that is considered responsive to 21st century market demands. However, to provide context, let us first consider the prevalence of chronic disease, the key issues, and the increasing demands that this is placing on our healthcare system and our workforce. The new millennium has heralded a health epidemic of global proportions. 50 years ago, the burden of ill health, disability and death were primarily attributed to acute infectious diseases. No longer. Today, chronic diseases are the leading global cause of death, with the World Health Organization estimating 63% of all deaths are today attributable to a chronic disease. In Australia, chronic diseases are also now considered the leading cause of illness, disability and death. According to Australia's Institute of Health and Welfare, in their report released in June of this year, 2014, currently 9 out of 10 deaths are today attributed to a chronic disease in Australia. An ageing population and changing lifestyles have contributed to the rising prevalence of chronic diseases. Local need within the Hume region is an echo of the global call to action to combat the rising tide of chronic diseases. International experience and lead public health authorities, such as the World Health Organization, are calling for new transformational approaches in how we educate our health professionals, and they are advocating the health sector must re-engineer many of its core capabilities, including the competencies of its people and workforce. Industry experience and growing evidence highlights the health sector must reform traditional models of care that predominantly favour an acute approach and what could be described as an episodic and even transactional response to the healthcare needs of patients or clients. On a regional level, this is being reinforced by CEOs from lead health organisations. Albury Wodonga Health's new CEO, Sue O'Neill, at their recent Health Service AGM, recognised the need for radical transformation on how services are today in this region are delivered in the face of an ageing population and lifestyle-related diseases that are creating burdens in our communities. Let us turn our attention for a moment to workforce competencies in chronic disease care and prevention. A review of literature and a search of Australian healthcare workforce standards on chronic disease care and prevention related competencies yielded surprisingly little. Despite chronic disease being recognised as an increasingly urgent nationwide priority, it would appear specific chronic disease care and prevention competencies and accreditation standards are yet to gain widespread endorsement as an essential criterion. Nationwide research was conducted by Flinders in 2008 to identify and evaluate chronic disease care and prevention skills bases and the training needs of the primary healthcare sector. The final report, released in January of 2008, found across the Australian healthcare sector there was a general lack of understanding of competencies related to chronic care disease and prevention, and also standards of practice. To foster healthcare reform, of course in chronic care related practices, in 2005, the WHO, as in the World Health Organization, conceptualised a set of workforce competencies designed for chronic disease prevention and care. The 5 core competencies that they developed and recommended were positioned to support or, if you will, augment existing workforce knowledge and skill sets, for example, clinical skills. They were not meant to supersede established competencies. So let's have a little peek at those. The 5 competency sets that the WHO developed in 2005 included the following 5 domains. First up was a person-centred care approach. 2, partnering capabilities. 3, a commitment towards quality improvement practices and processes. 4, the domains of information and communication technologies. And 5, competencies that related to public health perspectives. In America, the National Association of Chronic Disease Directors expanded on the World Health Organization's framework of 5 competencies to include an additional set of competencies targeting managerial levels. In recommending a set of competency domains targeting this particular cohort, the association recognised the knowledge, behaviours and skills of this cohort are key determinants of quality improvement practices, and they are influencers, or if you will, drivers of organisational change. The association organised the competencies over 7 management domains, and very broadly they covered the following domains of leading strategically, competencies relating to managing people, managing programs and resources, the capacity to design and evaluate programs, the ability to use public health science, and of course the very important capability to influence policy and systems changes, which is also very critical in this particular space. In the last few slides, we've touched upon workforce-related competencies and standards that have been established by some leading authorities, such as the World Health Organization and the American-based National Chronic Disease Association of Directors. We should also, though, consider the influence of Wagner's chronic care model, given its play and importance within how it informed the 2005 National Chronic Disease Strategy, and of course our own more regional Hume Region Chronic Care Strategy. Given the weight of Wagner's model within the industry, and of course these two overarching strategies, if we are to have any future deliberations on professional competencies, workplace competencies, and of course the correlating or subsequent educational competencies that may grow from that, we should factor also Wagner's recommendations. I offer you a little model just below on both how Wagner model and also the National Chronic Disease implementation domains interplay with each other. In the earlier slides, we considered the global, national and regional prevalence of chronic disease, and we also touched on the recommended workforce-related competencies recommended by lead organisations such as the WHO. Time now to turn our attention to the demographic profile of primary healthcare professionals in the Hume region. Turns out that the demographic profile is actually comparable to national trends. Our workforce is ageing, and our workforce is skewed to females who predominantly work part-time, often in job share arrangements, and in the chronic care space they have typically diversified from professional disciplines such as nursing, dietetics and occupational therapy, to name a couple of examples. Certainly not limited to those three professions. What is very typical though is that when a chronic healthcare specialist or practitioner arrives into this space, they typically have significant clinical experience in their primary discipline, for example, nursing. In Tallangatta, for example, to give you a local snapshot, 96% of their workforce is female, and leaning on their annual report of this year, 2014, 94% of them work part-time. So what development and training opportunities in chronic disease prevention and care have been offered to healthcare professionals over the past 12 months? A general search of the internet and looking at the local agency and provider training schedules for the past 12 months, it would appear that there has been somewhere in the vicinity of nearly 40 professional development training opportunities, workshops and or seminars conducted in one of the regional centres or in a local area. Of those recorded, which is an interesting point to notate, it would appear that only 3 of the workshops were accredited training courses. In terms of hours, 181 hours of training was offered over the last 12 months. And typically, in terms of length, that would equal that the most common session was 2.5 hours. If you were to refer to the discussion paper, you will be able to find in Table 5 a list of all the training workshops that were delivered in the region during 2014. However, for the purposes of this PowerPoint presentation, it was a little bit cumbersome to show you. What should also be pointed out to listeners of this PowerPoint and for also readers of the discussion paper, the sessions that are listed do not necessarily capture all training that was on offer across the Hume region over the last 12 months. And it does only capture sessions delivered in the Hume region versus any online or metro-based training. This study was also unable to determine outcomes and quality of training in terms of meeting any competency standards and/or student satisfaction. Something for us to consider perhaps moving forward. What was the view of our peers in relation to local education and training programs? It would appear the key issues that were identified at a national level definitely are mirrored in the experience of health professions within the Hume region. Anecdotal feedback suggests, in practice, professional development training appears to be typically delivered in an ad hoc piecemeal approach. Competencies were assessed as incomplete or lacking, and some were concerned that often the currency of the competencies that were a part of the training may indeed be outdated. From a student level also, there were concerns about how to apply new skills and new knowledge in practice. This was an ongoing concern or issue for them, as was how to facilitate behavioural changes in clients. The usual culprits of cost and time and budget and workforce backfill capacity were repeated and emerging themes across the Hume region. The peer review also highlighted understanding and knowledge about chronic care varied by profession. With general consensus, professional development opportunities were limited outside of metro regions. Of interest is the apparent lack of formal training offered to staff employed to drive chronic care prevention and care messages across the primary healthcare channel. What are the barriers to education and training? A review of available literature and anecdotal feedback point to systemic barriers with flow-on effects experienced at student levels. You will note on screen at regional and organisational levels there are common issues. The literature suggests the chronic care space has a low share of voice, with an acutely orientated sector predominantly focused on episodic transactional approaches to care. A lack of shared, well-defined workforce and/or training competency standards and, of course, definitions likewise appear to be undermining a given organisation's capacity to build chronic care best practices. Chronic disease education and training curriculum appear to be implicit in regional and organisational level strategic plans. At a student level, the regional experience indicates limited access to quality training and a perception that they cannot be released from daily tasks. For example, grey literature highlights in the lower Hume region there is a need to investigate online training on chronic care management that is appropriate and accessible. Additionally, Central Hume reported clinicians were time poor and low in practice confidence. In the Upper Hume, Recent recommendations highlight a need for recognised competency-based training in areas of shared care, care coordination and case conferencing to provide structure and process for person-centred approaches. Let us now turn our attention to trends in professional education and learning practices. What professional development approaches do teachers advocate? Federation University's Centre for Learning, Innovation and Professional Practice are proponents of collaborative learning approaches. Comparable to the plan, study, do, act paradigm within the healthcare sector, this learner-centred approach fosters teacher skill development and growth through peer review. Teachers collaborate on their respective ideas for best practice and through a peer-led lesson study. Learning and skill development is facilitated through the process steps of plan, do, reflect and revise. Flipped learning is a relatively new learner-centred approach gaining increasing popularity in secondary and tertiary education circles. EduCourse offers a simple definition. It is a model in which the typical lecture and homework elements of a course are reversed. Advocates of the flipped model highlight the key advantages of this approach are its ability to foster 21st century skills such as critical thinking, creativity, communications and peer collaboration. Somebody's doing the dishes in the background, so forgive the extra noise. In the Hume region, a working example of this innovative model can be found in the Bachelor of Applied Management course jointly offered by Federation University and Wodonga TAFE. The BAMS course is constructed on a flipped learning model. Students independently learn key topics each week with group workshops scheduled on average every 3 weeks. Students then leverage those workshops to engage and collaborate with their peers to apply their new learning and practice their new skills. An additional 2 hours per week is also usually allocated for online forum discussions with lecturers also available outside of workshops on a needs basis. To understand the effectiveness of competency-based education within general practice, a comprehensive evaluation of 365 research articles was undertaken by the Australian National University in 2008. The study provided supporting evidence that the primary healthcare sector is well suited to a competency-based approach and was more favourable over the traditional process-based education approaches. So what is competency-based education? Leaning again on EduCourse, they define competency-based education as an approach that allows students to advance based on their ability to master a skill or competency at their own pace, regardless of the environment. Key features of this type of model that makes this approach an attractive proposition include acquired knowledge and skills can be directly applied in the workplace. The model can also be leveraged as a quality assurance tool to develop, assess and measure workforce competencies against best practice. At a student level, competency-based education and the instructional design and modes of delivery typically offer a flexible and potentially personalised learning experience. The vocational education sector offers a broad range of accredited competency-based courses that meet Australian quality training framework compliance standards. An internet search on current endorsed training packages reinforces industry claims regarding the lack of explicit training designed to accommodate the training needs of the chronic healthcare sector. On screen, you can see some examples of individual units relevant to chronic disease prevention and care. What are the features of IPE or interprofessional education? It has a focus on learning through practicing with peers and across disciplines with other professions. It enables applied learning practices that support and mirror workplace practice. Its student-centred orientation fosters and rewards the acquisition of knowledge through the experience of practice. And given the existing structure of primary healthcare teams, for example, multiple professions from different disciplines working together, both interprofessional education and interprofessional learning may resonate naturally with this cohort and therefore offer lower barriers to adoption. Discussions. This slide offers 3 possible scenarios for the committee's consideration and debate. Scenario 1. During the course of this study, a frequent issue raised by practitioners and our channel partners was their feeling of isolation and limited access to subject matter experts who could offer high-level quality supervision, mentorship and coaching on complex issues. One idea from the region was to consider establishing a peer mentorship program leveraging the expertise of leading industry consultants. Scenario 2. If we consider the profile of chronic care professionals and or their teams, changes in service delivery, barriers to training such as geographical distances and funding streams, barriers to funding streams that should be, a cooperative community service approach as advocated by Alan may offer a cost-effective solution. Leveraging a method similar to CLIP's lesson study model, chronic care practitioners across the Hume could collaborate on their respective ideas for best practice and through a peer-led lesson study approach, learn and develop skills through the process steps of plan, do, reflect and revise. Scenario 3. Wagner's contribution was to introduce a client-centred paradigm and a structure that supported a team of professionals who in turn worked in collaboration with a person living with a chronic health condition. If we are to deliver superior value, it follows interprofessional education and learning is critical to retrain and reorient professionals from different disciplines towards effective collaborative practice and the chronic care paradigm. IPP and IPL are continuous professional development models that support the advancement of shared interprofessional practice competencies, capabilities, and learning outcomes. Overlaying a flipped construct to content, instructional design, and delivery may offer a unique differentiating point and student learning environment that will appeal to our time-poor, geographically challenged target cohort groups. Flipped learning could offer the Hume region a flexible, workable model of instruction. We're up to slide 17. If you're still here with me, thank you very much for your persistence. And good news, we're on the home run and we've only have a few more slides left to go. The earlier sections of this PowerPoint presentation documented, albeit somewhat briefly, the increasing pressure that is being experienced by the healthcare sector as it struggles to reorient its services and upscale workforce capability to better accommodate people living with a chronic healthcare condition. The key issues that have been identified at a national and even global level appear to be mirrored in the experience of healthcare professionals and our channel partners within the Hume region. The major themes that are emerging that for us to consider and deliberate on are the following points. We need to consider and identify policy agenda to explicitly address chronic disease education and training curriculum. We need to identify workforce competency agendas to support and reorient organisational policy and practice on chronic disease principles and benchmark some standards. Ideally, And perhaps this is definitely outside of the scope of this particular project, but at a later stage, should we consider and identify career pathways to support industry accreditation of chronic care practitioners? Looking and advocating for interprofessional cross-organisational coordination that would address chronic disease education and training curriculum is a theme for us to consider, as is collaborating with other major sectors, for example, regionally based education providers, and the very important one of engaging and involving our clients. Time to close. I'm sure you're relieved. In conclusion, chronic disease prevention and care curriculum is implicit in regional and organisational level strategic plans. Perhaps the central debate lies not in what model to adopt and how the Hume region develops a sustainable education and training program. Regional experience and growing evidence suggests determination of shared standards of accreditation and competencies, both workplace and educational, are the lead imperatives. The agility of the system to build share of voice and apply system-wide solutions are our core challenges. Likewise, our determinants of success will rely on the capability of the region to adopt a systematic approach in the delivery of training with the appropriate levels of organisational support and accreditation from relevant professional bodies. A short postscript. I should acknowledge and thank the following people. Thank you to the Medicare Local, Primary Care Partnerships and Primary Healthcare teams across the Hume region for their preparedness to share their insights, frustrations and their vision for change.